चलो सर,
चलो।
हाँ जी।
ठीक है, तो पहले गेस्टों वाले आएंगे, वो करेंगे। ये रिकॉर्ड हो रहा है, स्क्रीन कैसे जाएगा? अगर यूट्यूब पे समझ जाएगा, स्क्रीन शेयर, इसका स्क्रीन कैसे शेयर होगा? तो उधर से रिप्लाई नहीं आ सकता ना?
हाँ नहीं।
ओके। ये चल रहा है। ओके, अब मैं स्क्रीन अगर डालूंगा तो इंट्रोड्यूस कर देता हूँ उसको. Okay, shall we start? Very good afternoon. I am Dr. Rajesh from GI Surgery, Assistant Professor. Today we'll be dealing with a very important symptom called dysphagia. Dysphagia, the word implies, it's derived from Greek word phagia, which means eat, and dys with difficulty. So if somebody has a difficulty in eating, it is called dysphagia. It refers to a sensation of food which is either stucking in throat or lower down, and the impairment may be either due to the oropharyngeal cause, esophageal cause, and further can be divided into functional and structural problems. Dysphagia is a distressing symptom because the patient is feeling hungry but is not able to eat, so you can understand the plight of the patient. And it is also an alarming symptom because malignant, mostly the progressive dysphagia is a symptom of malignancy, and curative treatment is not possible in most of these cases. And it is also a late symptom because more than 2/3 of the lumen of the esophagus has to be compromised before this develops. So in this seminar we will be discussing about dysphagia as a symptom, its probable causes and evaluation. Dr. Soumya from Gastro will be dealing with the medical part, the medical evaluation. Dr. Madhusudan from Radiology will tell you about the radiological evaluations like barium swallow, X-rays and CT scans. So to begin with, I'll invite Dr. Soumya to deal with the medical aspect of dysphagia. Over to you, sir.
Good afternoon, guys. So happy Diwali to all, and I hope you all had a good Diwali celebration. So we should so today we will be discussing the benign and malignant disorders of the esophagus. So as you know, esophagus is the food pipe which continues from the oropharynx till the stomach. The function of esophagus is secretion of bicarbonate, transfer of food from pharynx to abdominal cavity, and anatomy. You all know this, but I want to just brief it for a few seconds so that we remember what is important and we discuss subsequently in the disease. So the length is 18 to 26 centimeters, which depends upon the length of the patient and the build of the patient. So it's the anteroposterior diameter is 2 centimeter and lateral diameter 3 centimeter, and when we in between the breadth it is collapsed. The upper third is a skeletal muscle, middle third of the esophagus is a mixed of skeletal and smooth muscles, and lower third is a smooth muscle. In the esophagus there are two sphincters, the upper esophageal sphincter and the lower esophageal sphincter. The function of the sphincter is to prevent passage of reflux of food from stomach to the esophagus of the lower esophageal sphincter. So you all know about esophageal peristalsis, so we'll discuss few seconds about esophageal peristalsis. So there are three kinds of peristaltic movement: primary, secondary and tertiary. So when you take out the food comes to the mouth, then it goes to the oropharynx, and there is a coordinated and propulsive movement of the smooth and striated muscles, which results in propulsion of food from the mouth till the stomach. So this is primary peristalsis. So suppose there is any other stimulus, means suppose you there is another stimulus. Suppose you stimulate mid esophagus somehow, either it may be due to iatrogenic when you are doing endoscopy, then it may also produce a propulsive contraction, but it's not in response to swallow, so we call it secondary peristalsis. And sometimes there is some contractions going on in the esophagus, which we can see irrespective of the swallow. It is due to local intramural mechanism, and we call it tertiary peristalsis. Suppose you take a barium swallow of the patient, and you see in the barium swallow some part of the esophagus is narrowed, some part is dilated, so the patient is having tertiary contractions. That's because after the swallow of the barium also there is some contraction in the esophagus, and the primary peristalsis has passed on, but the thing which is there, the contractions, that is tertiary, so we call it tertiary peristalsis. So we will briefly discuss benign disorders of the esophagus first, then we go into the malignant disorders. So what are the symptoms which are specific to esophagus? Suppose a gentleman who is suppose 50-year-old, who is a smoker and continuing 1 pack of cigarettes daily, and he present to you with difficulty in swallowing food, and you ask him, yeah, can you so how difficult it for you to swallow the food? Can you swallow solid? Can you swallow liquid? He says, yeah, I can take liquids comfortably, but I can't take solid. So then you ask, yeah, is there any difficulty in swallowing? Pain means swallowing food means, is there any pain during swallowing? So that's odynophagia, painful swallowing. So he denies, no, there is no pain, it's absolutely okay. Painful pain during swallowing means there is some esophageal ulceration that may cause pain, or there is some esophageal infection such as candidiasis that causes pain. And then you ask, so has the dysphagia been progressive? Yes, he says, yes, 6 months back I could take solid easily, but for the last 5 to 6 months I have been shifted to liquid. Yeah, that means the dysphagia is progressive. So you are dealing with some disorder in which there is difficulty in swallowing, and patient has dysphagia and it is progressive. That means patient has some disorder of esophagus which is progressive disorder of the esophagus. So this dysphagia, odynophagia, is very specific to esophagus. Other symptoms which are heartburn. Normally what you see, you take a heavy meal in a Sunday afternoon, so you did not wake up for in the morning for the Sunday breakfast, and you had a good brunch and you took some cokes or some fries, and after in the Sunday afternoon your stomach is full and you feel heartburn. So that is reflux. So there is retrosternal burning sensation, that's the heartburn, and that's the reflux. So that's not so specific for esophagus, because retrosternal dysfunction and burning you can see in other disorders which are not localized to esophagus. So but however, if you have any correlation with meal, you should think of something related to stomach and esophagus. Sometime there is spasm of the esophagus during intake of hot or very hot or very cold food, and you may feel pain. Some patients are very sensitive esophagus, they feel more pain, and that pain, retrosternal pain, may be related to esophagus, but predominantly if a patient has retrosternal pain, and you should evaluate for cardiac disorders. So we'll discuss first first is gastroesophageal reflux. As the name implies, there is reflux of acidic contents of stomach to the esophagus. So that's the acid and the pepsin, and that goes through gastroesophageal junction to the esophagus. So what are the symptoms? The symptoms are the patient reports of retrosternal burning post predominantly after meals. He may have some sensation of soury or food particles in the mouth. That's the reflux that comes to the oropharynx, to the mouth. So you can imagine so when you take a heavy meal, stomach is filled with the food and acid and the digestive enzyme pepsin, and if the lower esophageal sphincter is a little bit relaxed, there is reflux of content to the esophagus, which can come out to the oropharynx, come to the mouth, and it can go to the little bit go to the airways also. So if when a patient has a reflux symptoms, predominantly they report of retrosternal burning, but gradually in a prolonged reflux. Some patient also report a chronic cough. Oh. So let's discuss. So how common is the reflux? Overall, it is 10 to 20% of patients, 20% of general population report reflux. So, and we have done a study from our AIIMS in the employees in 2011, and we have shown that it is around 16.2%. The predominant symptoms were heartburn, regurgitation, and most of the patient have some symptoms in a week, and but there are a few patients who also report daily symptoms. If a patient has daily symptoms, you may have to give some therapy. If you have occasional symptom once in a week, once in a month, then it's okay, you don't need to bother. And severe symptoms were present only in 2.7%. It's a prevalent problem in the society, but very few require treatment. So what is the pathophysiology of the gut? So as you can see, so this is the esophagus, this is the lower end of esophagus gastroesophageal junction, this is stomach. So if there is impaired esophageal clearance, so there will be some food in the esophagus that may give sensation of the reflux. There is the lower esophageal sphincter. If there is so lower esophageal, so after you eat food, the lower esophageal sphincter is contracted. So sometimes it relaxes because it is a smooth muscle. It has a tendency to relax and contract. Though it has a job to contract and keep it in a tonic state, sometimes it relaxes. So like every other muscle. So some of the food content gets into esophagus, and we feel that reflux sensation. So these relaxations are called transient lower esophageal sphincter relaxation. So if there is too much of this transient lower esophageal sphincter relaxation, or the tone of the lower esophageal sphincter is decreased, there is increased reflux symptoms. If a patient has delayed gastric emptying, then the stomach would be filled with food, and there would be more of reflux. So the two most common symptoms which I have discussed: heartburn, regurgitation. Apart from this, you may have vomiting, dyspepsia, bloating, and other symptoms also. So there are some extraesophageal manifestation of gastroesophageal reflux disease. In the oral cavity, you may have oral ulcer, gingivitis because of reflux of content to the mouth. You may have pharyngitis, laryngitis, recurrent cough, bronchial asthma. Persistent reflux may result in stricture of the lower end of the esophagus, because there is continuous injury to the lower end of esophagus with acid and food and pepsin that causes injury to inflammation of the lower esophageal mucosa, and with continuous inflammation and healing, it causes a stricture which you call peptic stricture. It may result in change in the esophageal stratified squamous mucosa to columnar mucosa at the lower end with metaplasia, which is called Barrett's esophagus. So suppose a patient having chronic reflux, he develops dysphagia, odynophagia, or wet loss, you suspect some complication of the gastroesophageal reflux, such as stricture or Barrett's esophagus, and you should do a esophagogastroduodenoscopy, that's a upper GI endoscopy, to look for these complications. So how do we diagnose? So as I have told you, it's mainly clinical based on the patient's symptoms, and only a few patients who have persistent symptoms require investigations. So what all investigations you will do? So we will do investigation on the basis of if there is presence of abnormal reflux, if there is mucosal injury due to reflux, or are there symptoms due to reflux. So we would like to look how much reflux is there, means how much content is going from the stomach to the esophagus. So that can be done by prolonged esophageal pH monitoring, barium salon, nuclear scintigraphy. So that gives idea about the content of the reflux. we can see how much it has done injury to the esophagus or lower esophageal sphincter. For that we need to do a endoscopy to look for the esophagus and the stomach, and take biopsies, and then if you want to quantify everything, so you have to do a 24-hour ambulatory pH monitoring. So as you can see, this is the endoscopy view. The pink color mucosa, that's the esophageal mucosa. The red color mucosa, it's the stomach mucosa. And in the book there is description of this protrusion of this tongue shaped mucosa from the stomach till the esophagus. They call it salmon color. I don't know how much of you have seen the salmon fish or it color, but if it's such red kind of gastric mucosa projects into the esophageal mucosa, which is pink, and it is tongue like, and it is bigger than this, so there is not much protrusion, then we call it Barrett's. So we have to take biopsy of that area because this is metaplasia and it has a tendency to convert into adenocarcinoma. So so this is briefly about endoscopic examination. So what we see, we look for at this is the lower esophageal sphincter region. So this is briefly the Z line junction of the squamocolumnar junction. So we have to evaluate look for ulcers or any Barrett's, and if there is some abnormal area we take biopsies. So 24-hour pH recording is the gold standard for diagnosis of GERD, and you should always remember this. That's the gold standard of diagnosis of GERD. Yes, and you have to place a catheter which goes into stomach, and you have to record the pH recordings through this in different positions, such as lie down, upright, after meal and pain. So this is the pH recording. So the patient, when they lie down, the pH goes very low at the gastroesophageal junction, and as compared to the patient is upright, the pH is high, means there is more of reflux content in the lying down position. And you can see after a meal, so after a meal there is not much difference. So to summarize, when you are planning to diagnose a patient with gastroesophageal reflux disorder, you need to see the symptoms such as heartburn and regurgitations. If the patient has such symptoms, then you need to look for alarming symptoms, such as if the patient is developing any dysphagia, which may be a sign of peptic stricture, or a Barrett's leading to adenocarcinoma. In that case, you may like to do esophagogastroduodenoscopy. If the patient does not have any alarm symptoms, you would like to give him some proton pump inhibitor and do the follow-up, and you don't want to investigate them much unless the patient has persistent symptoms. So I have briefly summarized you regarding this. You have to advise them some lifestyle modifications, such as you have to give a 2-hour break between a dinner and a bed. You have to avoid fatty spicy food, you have to avoid citrus food, you have to stop smoking. That's the most important. And remember, if you are obese and your BMI is more than 30 or more than 28, there is high chances of having reflux. Yeah. So sometimes exercise and weight reduction help them much in reducing the reflux symptoms, and believe me, these dietary modification, exercises, weight reduction are the best advice are you going to give a patient, rather than giving them a pill. And pill is going to work for a few months and the guy is going to be dependent upon pill. Then you need to do some surgery, endoscopy, blah blah blah, and all these things can be managed very easily with dietary modification and weight reduction. So these are the drugs, S2 receptor antagonists. You normally need to give it twice a day dosing, and these are the proton pump inhibitors. So once a day we normally give. Which PPI you need to choose? Almost all have similar efficacy. So, and what time should be the intake of PPI? That should be 30 minutes before the meal, because as you know the mechanism action, the These are proton pump inhibitors, so they need some time to inhibit the proton pump, so that their maximum secretion of the acid during meal should be inhibited. So you need to give at least 30 minutes before the meal. You need also to give some prokinetic drug if you like: metoclopramide, domperidone, etopride, levosulfide. uh, so to summarize, for acute management, appropriate lifestyle modification and PPI is the key. Long-term management, those dietary therapy and exercise, these would benefit most. But if patient have alarm symptoms, then so if the patient have typical symptoms, you need to give PPI antacids, and if there is relief, you need to maintain them with step down therapy. If there is recurrent symptoms, you intensify PPI. And if the patient is completely dependent on PPI, then you need to sort for some endoscopic or surgical therapy for gastroesophageal reflux disease. Or sometimes you add some amitriptyline or some other SNRIs, so and these guys benefit. So this is a individualized therapy. You have to assess the patient, you have to assess his symptom and treat according as per his symptom. So how long you have to treat, that's a big question. We really don't have the answer. Generally people think they have to take indefinite, but for immediate relief they take antacids. But if they have persistent symptoms, they may require surgical therapy. But as of now, there is no definite role of endotherapy in gastroesophageal reflux disease. There are few modes of endotherapy. This is radiofrequency application. There is some magnetic device which we apply at the lower esophageal sphincter, that is magnetic lower esophageal sphincter augmentation, that is implanted externally to both the sides of the implanted externally over the stomach, at the lower esophageal sphincter, along the esophageal and the stomach side, and it augments the lower esophageal sphincter through magnetic waves. But these all are experimental. If patient have persistent symptoms such as who are dependent on PPI, having severe gastroesophageal reflux disease, bad esophagus, hiatus hernia, and there is hypotensive LES, and then you need to do a surgery. So this is the anti-reflux surgery. So to summarize, we have discussed all this. Gastroesophageal reflux is a common disease diagnosed mainly on the clinical grounds, and patient initially require PPI for 8 to 12 weeks. If there is a recurrence or maintenance is required, then you have to titrate as per the patient. Underserved patients should be referred to specialist in this disease and should undergo further evaluation for the cause or surgical therapy. So dysphagia, we have discussed dysphagia, that is difficulty in swallowing. What are the types of dysphagia? The dysphagia can be due to oropharyngeal dysphagia, means patients have difficulty in swallowing the food. We call it transfer dysphagia, oropharyngeal dysphagia, or dysphagia may be due to esophageal cause. So localization of dysphagia is most important. Sometimes patient points out where there is difficulty in the food. He may point out to the upper esophagus, in the mid, that he may point out, or sometimes he gives history, he or she gives history of when he is trying to swallow the food, comes out to the nose, or there is some palatal hypotonia, there is some nasal twang to the voice, and you can then decipher that this is some disorder of the oropharynx. Patient have some CNS disorder due to probably some nerve palsy, that's why he or she can't able to swallow the food. So this is the type of dysphagia we call transfer dysphagia. So oropharyngeal dysphagia, and if they has lateral, So that's the esophageal dysphagia. So we have discussed this orophageal dysphagia causes are mostly pertaining to CNS, CVA, Parkinson disease, multiple sclerosis, ALS, brainstem tumors, tabes dorsalis, and some peripheral nervous system disorders such as the which affect the cranial nerves, such as bulbar poliomyelitis. Sometimes it may be due to muscular dystrophies also. Some local causes are also there, and it is a disorder of the predominant upper esophageal sphincter. So esophageal dysphagia, it may be due to mechanical obstruction, which may be stricture. Stricture may be benign, such as due to acid, which is peptic stricture, due to corrosive ingestion, due to drugs, due to webs and ring, or it may be due to cancer, or it may be due to vascular anomalies such as there is enlarged aorta, or or it may be due to motor dysphagia, means that is due to defect in functioning of the esophageal muscle. So that we call achalasia cardia, means if there is a defect in peristalsis so of the esophageal muscle and there is hypertensive LES, we call it achalasia cardia. Other primary motor dysphagia of the esophagus are diffuse esophageal spasm, nutcracker esophagus, hypertensive LES, and all these changes can happen to other disease such as Chagas disease, you know, that's mimics achalasia cardia, diabetes, scleroderma, hypothyroidism. So normally esophagus is a big luminal structure with 3 centimeter diameter. So patient has so from the diameter, so suppose a guy develops a malignancy, carcinoma esophagus. So when the esophageal lumen becomes 2 centimeter, he does not have any symptoms. When it 1.5 centimeter, he does not have any symptoms. When it's decreased to less than 12 millimeter, this guy develops symptoms, and that causes dysphagia. And gradually further compromise of the lumen, the symptoms of dysphagia increases. So this we have all discussed. So differentiation from mechanical and motor dysphagia is important, because motor dysphagia is due to primary disorder of the esophageal muscle. Mechanical dysphagia is due to some obstructive lesion. So how will you differentiate both the disorder on the basis of history? Suppose a guy gives symptoms which is fluctuating symptoms, when dysphagia is fluctuating, then it's more suggestive of a motor dysphagia, because there is sometimes there is more dysfunction of the muscle, and sometimes it improves, so that gives diagnosis of motor dysphagia. Normally malignancy and other benign diseases are progressive, like the strictures are progressive. So the mechanical dysphagia are mostly progressive. They have a shorter durations, few months to a year, but a disorder which is lasting few years, that is probably that's a motor dysphagia, probably like achalasia cardia, they present with history of few years. So if there is esophageal peristaltic defect, means you need peristaltic defect, then solid food can pass with the aid of gravity, but you will have difficulty in swallowing liquids. So predominantly dysphagia to liquids denotes motor dysphagia. Dysphagia to cold means cold or hot means that means there is increased sensitivity of the esophagus. So like this nutcracker esophagus and other esophageal motor disorder, they have highly sensitive to temperature, and with high or cold temperature the muscle suddenly spasm, that causes dysphagia to cold. So these features are important in differentiating a mechanical from a motor dysphagia. So differentiation from benign and malignant causes in mechanical dysphagia is also important. So how will you differentiate? Number one is course. So normally patient with malignant disorder have a progressive course, and benign disorder they have a static course. And duration of malignant disorders is shorter, they have persistent symptoms, and you know the causes. So how will you investigation? The best investigation is to do a upper GI endoscopy. You can get a guide of whether there is a mechanical disease or a motor disease on the basis of barium swallow also. If you suspect a malignancy, then you have to do a CT scan. If you suspect a motor dysphagia, then you have to do esophageal manometry. Coming to the mechanical causes, the strictures, this may be benign and malignant. As you can see, this is the endoscopy view. So this is a typically benign stricture. So this is a malignant stricture with sorry, this is a benign stricture. All these are peptic stricture. So there is continuous acid injury, inflammation, and that leads to this pinhole stricture. So peptic stricture is long-term complication of gastroesophageal reflux. We have discussed it, and we can take care of the stricture on the basis through endoscopic dilatation by either boogie dilatation or balloon dilatation, and we have to treat for underlying gastroesophageal reflux disease. Corrosive stricture, patient normally present after a corrosive ingestion. So we do endoscopy within 24 to 48 hours to look for to create the injury of the esophagus, and there is inflammation, injury, necrosis, and later on after 4 to 8 weeks patient develops stricture at that inflamed area because the mucosa and submucosa muscle they have healed, and that produced a stricture. And so acute phase, you have to take care of the injury by protection of airway. You don't have to put a rice tube. You have to give don't have to give steroid. You have to give only supportive care. And if the patient is unable to take orally, if there is severe injury, you have to do a feeding gastrectomy. But in so after 4 to 8 weeks, when the patient develops a stricture, you may dilate the stricture, or so this is the esophageal stricture. You can dilate with the boogie dilator or a balloon dilator. So sometimes so this is predominantly some patient develop outpouching of the mucosa of the esophagus through a defect that we called esophageal diverticulum. This is the endoscopy view. This is the normal esophagus lumen. This is the diverticulum. So when this diverticulum appears at the upper end of the esophagus, just between the inferior constrictor and the cricopharyngeal muscle, we call it junctional diverticulum. So so now we should discuss briefly about esophageal malignancy. And the so most common site of the esophageal malignancy is lower 1/3, which is mostly adenocarcinoma, and upper third and middle third comprise 20 to 30% of malignancy, mostly are squamous. The symptoms and signs we have already discussed. So this is the endoscopy view of a lesion in the lower end of esophagus, and that is on biopsy this turned out to be adenocarcinoma, but it is localized, and we have taken care of this lesion with endoscopic resection, so the endoscopic submucosal dissection. So however, this malignant obstructing lesion is a big lesion, and probably it has also extension to the surrounding lymph nodes, and there is ulceration. So this is also similar picture of a G junction tumor. So the diagnosis on the basis of doing an endoscopy and taking a biopsy, you need to evaluate the extent and stage of the tumor. So for this you need to do a CT scan. If the tumor is localized, then means it is localized to mucosa and submucosa, you can do a local resective therapy such as endoscopic submucosal dissection, in which you dissect the mucosa and submucosa endoscopically and take that out. Sometimes that's curative. If this fails, then you have to go for a surgical resection. If the patient is not surgically resectable, they have persistent dysphagia, you can put a esophageal stent across the lumen. So this is another lesion, so small lesion at the just 2 to 3 centimeter proximal to the G junction, and on evaluation this is a uh, lipoma. This patient did not have any symptoms. Now we'll briefly discuss a few minutes regarding motor dysphagia. So the the predominant disorder of motor disorder dysphagia is achalasia. Achalasia is the primary disorder of motility of lower esophagus. It predominantly affects the LES sphincter, which causes hypertensive LES sphincters. However, all the smooth muscles of the esophagus are also affected, and this results in epistaxis. So, for to diagnose achalasia, you should have absent peristalsis of the esophagus as well as increased tone of the lower esophageal sphincter, both in resting and with food also. Remember, the resting tone is also increased. Pathophysiology, so there is degeneration of nitric oxide producing inhibitory neurons that produces more of the neurons which are exciting, and this produces hypertensive lower esophageal sphincter. Believe me, we really don't know why this disease happens, but similar type of feature happens in Chagas disease, in which there is an infection of the ganglia of the infection of the neuron supplying the lower esophageal sphincters, the inhibitory neurons. So that produces similar symptoms. So the features is there is simultaneous contraction of the esophageal muscles that produces aperistalsis. There is increased lower esophageal sphincter pressure. Normal pressure is 20 to 40 millimeter mercury, and the lower esophageal sphincter fail to relax during swallow. The symptoms of the patient at presentation are predominantly symptoms of the symptoms pertinent to the esophageal disease: dysphagia, chest pain. If the patient has persistent symptom, there is dilatation of the proximal esophagus, which may lead to regurgitation of contents in the esophagus, and it may cause chronic cough, microaspiration. So the diagnosis on the basis of esophageal manometry, you put a catheter like this. We will have a slide here. Okay, all right. So you put a catheter from the mouth to the stomach, and you measure the pressure at each and every point. The normal lower esophageal sphincter pressure is 0 to 20 millimeter mercury. Intragastric pressure is 5 millimeter mercury. Esophageal pressure is negative, it's -5. So this is the esophageal manometry diagram of the achalasia cardia. So this area represents to the, as you can see in the type 1, this area represents to the esophagus, and this lower line represents to the GE junction. This is the upper esophageal sphincter area. So there is complete absence of peristalsis and increased lower esophageal sphincter during LES pressure during swallow. So this is type 1, which is classic achalasia, in which there is complete absence of esophageal peristalsis. If there is some esophageal peristalsis present, but it's not coordinated, that's type 2. Type 3 achalasia is the type of achalasia in which the esophageal muscles are hyperactive and they contract non-coordinatingly very strongly. So that causes a spasm. That is achalasia with spasm. That's type 3 achalasia. On barium study, you can typically see a Barbic appearance. Secondary, so symptoms similar to achalasia can also occur in cancer and other motility disorders also. So you need to, so to treatment, that is medical therapy. You can give nifedipine, botulinum injection to the locally, or you can treat it endoscopically through pneumatic balloon dilatation. You dilate the lower esophageal sphincter and produce a fracture of the lower esophageal sphincter by balloon dilatation of balloon size of 30 millimeter or 35 millimeter, depending upon the build of the patient. Or you can cut the lower esophageal sphincter endoscopically. That's the procedure is called paroral endoscopic myotomy. You might have heard of it. It's called POEM. So that's the procedure which is now gaining momentum over last few years, and our center is doing it almost every once or two, almost every week. That's a new technique, and it has gained wide acceptability due to its efficacy and safety, which is nearly similar to the surgery. And you can do a surgical cardiomyotomy, in which you cut the lower esophageal sphincter muscle and lower 2 centimeter of the esophageal both circular or circular longitudinal muscle. That can be done in laparoscopically or surgery. So we have discussed, this is the ballooning and fracturing of the lower esophageal sphincter by a pneumatic dilatation, and we have all discussed all this. So to summarize dysphagia, there are 4 types of dysphagia: oropharyngeal, esophageal, obstructive, and motor. Okay, thank you. I would like to so I would like to invite Dr. Madhusudan to tell about the radiological aspects of the dysphagia. So have a nice day.
शेयर होता है क्या?
हाँ सर, स्प्रेड के स्टार्ट कर लीजिए, डायलिसिस ही हो रहा है डेस्कटॉप से।
नहीं, कुछ लिंक भेजना है क्या कहीं, या
नहीं, खोल के बस
स्क्रीन शेयरिंग है?
स्क्रीन शेयरिंग है।
सीधा बोल। Hi, good afternoon. So let me focus on the imaging aspects of dysphagia. So these are the list of radiological modalities which are available for evaluation of any patient presenting with dysphagia: barium swallow or esophagogram, and then CT, MR, US, and PET CT. So let us discuss each of them briefly and the role each of these modalities play. So this is the barium swallow. So barium swallow, you evaluate from the level of oro or hypopharynx to the level of G junction and the stomach. And because now endoscopy has come up, and endoscopy has become the first modality of choice in all these patients, so barium swallow or barium upper GI studies have gone into disuse, and it has very specific indications now. One is motility disorders, because it can help in real-time assessment of the motility of the pharynx, esophagus, as well as the stomach, and then in assessment of leaks and fistulas, whether it is preoperative whenever there is a malignant fistula, or in a post-operative setting when there is leak in from the site of anastomosis. Then contrast enhanced CT scan is the most commonly used modality if endoscopy suspects a mass lesion in the esophagus. So this is the CT scan. So this is typically done either with the administration of oral contrast or air. So there has to be a contrast or some agent to distend the esophagus. Once the esophagus is distended, then it's easier to assess whether the esophagus is normal or abnormal. In a collapsed esophagus, it becomes difficult to assess if there is a small lesion or not. Thus, CT scan is helpful in making a diagnosis, in staging of the disease, and in follow-up of these patients after surgery or any kind of endoscopic treatment. CT esophagography is a modification of CT scan. Here we inject lots of amounts of air, ranging from 5 liters to 8 liters of air is continuously injected during the acquisition of the CT scan. So what happens is the esophagus is very well distended, and any abnormal thickening in the wall is very well visualized. Like in this case, these are the coronal CT images. You can see this part of the esophagus is very well distended, whereas this segment is showing wall thickening both on the right side as well as on the left side. And these are the axial sections at this level. You can see the wall thickening here. So there is asymmetric kind of wall thickening. Thickening here is less, thickening here is more. Whenever there is asymmetry, malignancy is the likely possibility. So unlike the esophagus here, which is showing normal appearance, you can see the wall is very well distended, it's very thin. Here it is very thick, okay. And this is the virtual volume rendered images where you can see the dilated esophagus, and then this is the strictured segment, and then this is the stomach. Okay, and then we can create virtual endoscopy images also. From this you can see the luminal narrowing at the site of stricture. Then you have endoscopic ultrasound. Dr. Soumya must have discussed this. So on endoscopic ultrasound, typically esophagus shows these multiple layers because of the presence of submucosa, muscularis mucosae, and muscularis layer and the adventitia. So all these produce different kinds of bands: hyperechoic, alternative, hyperechoic, and hypoechoic bands. Whenever this morphology is lost, as in this case there is a large mass lesion here on one side, whereas on the other side it's having this alternative band pattern. So whenever this is lost, you can suspect a lesion in that location. MR is uncommonly done in the evaluation of dysphagia because barium and CT are the most common investigations, and complemented by endoscopy. So these three modalities are usually sufficient. But in certain situations, like in patients who have renal failure or who are allergic to attenuated contrast, a contrast enhanced CT may not be possible. So in such situations, MRI can be done. This is one such case where you can see a lesion in the gastroesophageal junction. So these are the T2 weighted coronal images, and these are the T1 weighted axial images. You can see the thickening, asymmetric thickening causing narrowing of the gastroesophageal junction and the cardia of the stomach. And so there is additional sequence which is available, is the diffusion weighted sequence, which assesses the diffusivity of water molecules or protons within a tissue. So any tissue which has very high cellularity, like in case of malignant tumors, you can have this restriction of diffusion. Okay, and so this helps in defining the extent of the disease as well. PET-CT is mainly used for staging the disease. It can help, in addition to evaluation of the local disease, it can help in the detection of extra metastatic spread as well. Okay, and then it's also useful in assessing the response to treatment. Any patient who has been given neoadjuvant or palliative chemotherapy or radiotherapy, you can assess based on the reduction in the uptake. So based on that, we can see whether the patient has responded to treatment or not, and also during follow-up of these patients after surgery has been done. These are the list of causes of dysphagia, and let's evaluate each of these things on imaging. So esophagitis is, again, imaging is hardly done. Endoscopy is alone enough for making a diagnosis of esophagitis, but still in previous days when barium was being done, you can see this multiple ulcer. This is a double contrast esophagography where barium as well as air is effervescent is injected to distend the esophagus, and you can see multiple well-defined ulcers which is spread throughout the mucosa. Okay, so this is ulcerated, and this is more like esophagitis. And this is another case of patient who is HIV positive, and this is candida esophagitis. You can see that the mucosal abnormalities are better seen on a collapsed phase or a mucosal relief phase. This is the distended phase where mucosal evaluation becomes difficult, whereas on a collapsed phase, the barium which is present coats the wall mucosa, and then once the barium is completely passed into the stomach, you can see the retained barium in these ulcers, and they show the mucosa better. Then you have Schatzki's ring. Schatzki's ring is a ring which is present right at the level of G junction. This is better visualized whenever there is a hiatal hernia. So this is the herniated portion of the stomach which has gone up into the mediastinum, and whenever this constriction is less than 13 mm, then that is the time when it causes symptoms. The patient will present with dysphagia. Okay, and so this is a very well-defined, thin-walled, smooth circumferential ring which is present right at the gastroesophageal junction. Then you may have pharyngeal web, which is typically associated with the Plummer-Vinson syndrome. They are seen as a shelf-like projection on the anterior wall of the hypopharynx. Then you have diverticuli. The Zenker's diverticulum is the one which is present at the level of upper esophageal sphincter. There is weakening in the posterior wall, and you can see the bulging of the mucosa through the defect, and projects out in the form of a diverticulum. And this is the CT scan as well, which shows this air-filled diverticulum in the region of the hypopharynx. This may result in halitosis, retention, regurgitation of the food material, and if it grows large, this may compress the normal lumen of the pharynx and cervical esophagus, resulting in dysphagia. So this is epiphrenic diverticulum. So this diverticulum can be large, as in this case, and often these are true false diverticulum because it has only mucosa as a wall, and they are often associated with motility abnormalities, as in this case you can see a large dilated sigmoid esophagus which is seen in achalasia cardia, and this is associated with a large diverticulum. Then you can have hiatus hernia. Again, barium sometimes may be useful in diagnosis of hiatus hernia, whether it is prolapsing type of rolling type of hiatus hernia or a sliding type of hiatus hernia. And when the hernia is huge and the entire stomach is in the mediastinum, there may be associated volvulus also. Then achalasia. So Dr. Soumya must have shown you some cases. So this is a condition where there is lack of primary peristalsis of the esophagus and the lower esophageal sphincter is not relaxing. So this produces a bird beak kind of appearance or a rat tail kind of configuration, and the esophagus is grossly dilated proximally, and there may be multiple tertiary contractions which are non-propulsive. So this is a situation where barium helps in making a diagnosis of achalasia cardia and also grade the severity of it. And this is a grossly dilated esophagus, which is called sigmoid esophagus, because it is a long-standing disease and the esophagus becomes grossly dilated, looking like a sigmoid colon. So one important differentiation which needs to be done in case of achalasia is a pseudoachalasia, which develops whenever there is a tumor in the gastroesophageal junction. So sometimes tumor also can result in stricture, but unlike in the previous case, this site of location of this stricture is not smooth. You can see here there is irregularity and lobulated outline of the margin of this stricture compared to what we saw the rat-tailed appearance in the previous one. And then on a CT scan you will be able to see the mass as well at that location, asymmetric wall thickening compared to some circumferential wall thickening seen in the case of achalasia cardia. Then barium may help in the diagnosis of other motility disorders. This is a diffuse esophageal spasm or a corkscrew esophagus, where the entire muscle of the esophagus contracts simultaneously, resulting in non-propulsive contractions. And presbyesophagus is a age-related disorder where the muscle contractions become weak and there is more of tertiary contractions and less of primary contractions. Peptic strictures. Again, these structural diseases are all diagnosed on endoscopy, and barium is rarely done, but for estimation of the location, sometimes barium is done to give an overall picture of the severity of the stricture and the extent of the stricture. So this is a case where there is hiatus hernia, and because of repeated reflux in presence of hiatus hernia, there is a stricture which has developed in the distal esophagus. So a peptic stricture. So you need to differentiate benign strictures from malignant strictures. Benign strictures usually have a smooth margin, and then proximally it has tapered margins proximally as well as distally, compared to a malignant stricture which will have shelves because of the tumor and have irregular margins. And then corrosive stricture is another type of benign stricture. So typically it has, again as I said, benign stricture or smooth margins. You can see here the distal mid and distal thoracic esophagus is completely narrowed and has very smooth margins. The margins are very smooth. And then this is another case of corrosive stricture where the antrum and pylorus shows a long segment stricture and very tight smooth stricture. Okay, so there is smooth stricture, this part is underdistended and this part is tightly strictured. So presence of smooth outline and presence of long segment strictures are suggestive of a benign stricture. Then leiomyoma is another esophageal tumor. It's a benign esophageal tumor which can cause luminal compromise and thus dysphagia. So this is a barium study where you can see in a full-fledged barium you may not be able to see the tumor easily, but there is subtle indentation on the wall of the esophagus on the barium if you see, and the CT scan shows this mass very well. So it's a large mass causing indentation of the lumen and then cause dysphagia. This is a US picture showing the well-defined lesion, and it's a submucosal lesion. So on endoscopy the mucosa will be normal, but if you do an EUS you can see the mass lesion in the submucosal layer. Then finally coming to the carcinoma of esophagus. So the mass may be subtle, causing irregular ulcer here. So this is small irregular ulcer in the wall of the esophagus. This is a subtle lesion or a severe obvious kind of a lesion where you can see irregular stricture here. The lumen is narrowed, the margin is irregular. There are deep ulcers here where the barium is entering deep from the outline of the esophagus, and then this is called the shouldering, which I was mentioning. There is abrupt transition from the site of the stricture to the normal mucosa. So there is more shelf-like projection, which indicates that this whole thing is the tumor. And this is another case of carcinoma of esophagus. You can see multiple filling defects, which are polypoidal lesions of the component of the esophageal mass. And then this is a G-junction tumor. You can see there is narrowing here. This part may be smooth, but this part is all irregular and lobulated in outline. So there is a part extending to the fundus also, giving lobulated outline. There are these sharp V-type projections here, beak-like, which are ulcers seen within the tumor. And CA esophagus CT is the investigation, as I mentioned earlier. It helps in local staging as well as distant staging of the disease. So among the local staging, you need to evaluate the involvement of the trachea, bronchi, the aorta here, the vertebral body. So with respect to the involvement of the aorta, any involvement for more than 90-degree angle of involvement. So where you draw two lines from the center of the aorta to the outer margins of the point of contact with the esophagus. So it's a esophageal mass. So if this angle is more than 90, then there is high chances that the aorta is involved by the tumor. And then this is the bronchial involvement. You can see that it's completely encircling the left bronchus and also partially encasing the bronchus, suggesting involvement. These are the cornal sections of the same and sagittal sections of the same, which defines the extent, longitudinal extent of the disease. So as I mentioned, so the local extension, you need to evaluate the involvement of the airway. So here you can see that the airway is normal, the wall is also normal, whereas in this case you can see the right bronchus is normal, whereas left bronchus is narrowed and shows wall thickening, suggesting that it is involved by the mass. Here you can see that the involvement of aorta is more than 180 degrees, suggesting invasion. And then this is the trachea, it's also showing bulging along the posterior wall, suggesting invasion. So you need to evaluate the airway as well as aortic involvement. Then look for presence of any metastatic disease. This was a case of esophageal lesion. You can see metastatic lymph node in the left gastric location and focal lesion in the left lobe of liver. And then this is another case where you can see a locally advanced disease. The aorta is involved, the bronchus is involved, and then there was a metastatic deposit in the sternum. Then PET, as I mentioned, it helps in evaluation of the local disease as well as the metastatic location of the disease. This is the CT image. So PET CT is a combination of PET image as well as CT image. It gives a fusion image. So this is the PET image which shows the uptake, but anatomical localization is difficult. So when you combine both PET as well as CT, you get both anatomic as well as functional information. So here in this case, you can see this is the primary lesion and there was a small node adjacent to it. These are the axial locations, the primary tumor here showing uptake, and then this is the node which is adjacent to the primary tumor. The liver was normal, there was no uptake, separate uptake in the liver. So in conclusion, endoscopy is much superior for mucosal lesions. That is why esophagitis, Barrett's ulcers are all better seen on endoscopy. And barium swallow and CT are the mainstay when it comes to imaging in patients with dysphagia. US and MR have role in selected patients, and PET CT is used in staging and restaging of patients with esophageal carcinoma. Thank you. Now I call Dr. Rajesh for the surgical management of patients with dysphagia.
Good afternoon again. So Dr. Soumya has touched the medical aspect of dysphagia, and Dr. Madhusudan has explained regarding the radiology of dysphagia.
Your 3 to 4 is the LT2.
We have a seminar from 2 to 4.
3 to 4 is
2 to 4 is our seminar, integrated seminar.
2 to 4. I think they have given. I think I checked with LT again.
It's going on. Sorry for that. So Dr. Madhusudan touched regarding the radiological evaluation. So before flooding you about too much of information, we'll just recapitulate the concepts. So dysphagia is difficulty in swallowing. To understand the concept of dysphagia, you need to first understand what is swallowing. When we eat, the first thing that happens is you transfer the food from your hand to your mouth. First, then the teeth and the mastication process and saliva, they prepare the food bolus. This bolus is then transferred from the mouth through the oropharynx into the esophagus, and then from esophagus the food goes by peristalsis into the stomach. So this is the whole process of swallowing. So dysphagia can occur if there is any problem in any of these processes. So if suppose somebody is edentulous, so they won't be able to chew, so they won't be able to take solid food. If somebody is not producing enough saliva, like the disease called Sjogren syndrome, so they won't be able to prepare the food bolus properly, but they will also have dysphagia. Then if somebody has problem in the oropharynx, then because the process of swelling requires coordination of all the muscles of the oropharynx to transfer the food bolus from oropharynx to esophagus. If there is any difficulty, any structural lesion, any neuromuscular disorder, it can cause any discoordination in those muscles, can lead to dysphagia. And then finally, if there is some obstruction or there is failure of peristalsis in esophagus, it can cause esophageal dysphagia. So we already know that it's a very distressing symptom for the patient, and it is an alarming symptom because malignancy is a very common cause, and it's a late symptom because more than 2/3 of the luminal compromise has to be there before dysphagia develops. So esophagus is a tube, and if there is only partial obstruction of the tube, it can dilate a bit, and then there is still no dysphagia. So at least 2/3 of the lumen of the esophagus has to be obliterated for somebody to develop significant dysphagia that will bring him to a hospital. So for evaluating dysphagia, it is very important to first classify it into whether it is a structural lesion or a functional lesion, whether it is a anatomic obstruction or it is because of any neuromuscular disease. So these are the pointers that will suggest the possible diagnosis: the onset, duration, progression, severity. So all these will lead to specific diagnosis. So if dysphagia has been there for a longer duration, it generally points towards a benign cause, and if it is a recent onset, then more likely to be malignant. Then if it is progressive, then more likely to be malignant. If it is intermittent, more likely to be benign. More severe symptoms will be for disease which cause complete obstruction, like malignancy is one. Okay, so the history will point towards a possible diagnosis. It has to be differentiated from globus sensation. Globus sensation means that the patient complains of a lumpiness in the throat, but they actually do not have any dysphagia, so they can swallow normally. Odynophagia is pain during swallowing. It can happen without any luminal compromise. If there are esophageal ulcers or any infection of the esophagus, they will cause pain during swallowing. But the patient can still swallow, but they have pain while they try to swallow. So it is called odynophagia. And xerostomia, like in Jogren syndrome, can have difficulty in preparation of food bolus, and they can also lead to dysphagia-like symptoms. But actually, they don't have dysphagia; they have problem in food bolus preparation. The severity of dysphagia can be graded from normal swallowing to not able to swallow even their own saliva. It can be graded on a Likert scale, and this tells you about the severity of the disease. So this is one method where you can actually grade the severity of dysphagia. So you have to classify whether it is oropharyngeal. Oropharyngeal means that starting from the oral opening till the upper esophageal sphincter. If there is abnormality in this part, then it is called oropharyngeal, and if it is beyond upper esophageal sphincter, it is called esophageal. Structural means there is any anatomical obstruction, and neuromuscular means there is functional problem. Intrinsic means, if it's more specific for esophagus, intrinsic means the disease lies in the esophagus. Extrinsic means the esophagus is being compressed by something that is lying outside. So extrinsic cause can be any lymph nodes which are outside, like any other structure like thyroid, which is compressing, the enlarged thyroid is compressing the esophagus. This is an extrinsic form of dysphagia. So intrinsic is within the esophagus, extrinsic is something which is compressing from outside. A large aneurysm, a large tumor outside the esophagus can also compress the esophagus, called dysphagia. So these are the various etiologies of oropharyngeal. They can be structural or neuromuscular. Neuromuscular diseases are more common in this area because usually the stroke, they can lead to discoordination of the muscles of swallowing and thereby cause dysphagia. These neuromuscular causes will also be associated with choking sensation while the person tries to swallow. They can have nasal regurgitation of feeds. So these associated symptoms can help in differentiating neuromuscular causes from obstructive causes. Again, esophageal dysphagia can again be divided into mechanical causes or neuromuscular motility disorders. Mechanical lesions are the strictures, the most common, and neuromuscular will be achalasia, and other neuromuscular disorders, they will be most common, as Dr. Soumya has already pointed. So gastroesophageal reflux disease was is a common disease that Dr. Soumya pointed out that it was 16% incidence among the healthcare providers. So peptic stricture is not as the dysphagia is not a symptom of GERD per se, but it is a symptom of complication of GERD. When reflux disease complicates into peptic stricture, these patients will have dysphagia. Although GERD is very common, peptic stricture will not that be common. And because GERD is very common, the peptic stricture is the most common cause of dysphagia. Okay. And then other structural lesions like malignancy, after peptic stricture there will be malignancy. Thus the common causes are obviously the GERD complications are the most common, then the tumors, then corrosive strictures. If somebody takes some corrosive substance, then they can develop strictures, and this can cause dysphagia. And neuromuscular, most common will be achalasia. Now because most of the other medical causes have been dealt with already by my gastroenterologist colleague Dr. Soumya, so we'll focus more on the surgical causes. Let's talk about the tumors first. So esophagus has is implicated in many malignant and benign tumors. Malignant are by far the most common, and benign are rare. Okay, so if there is a tumor in esophagus, more likely to be malignant. World over, adenocarcinoma has become the more common one, the lower third, because it is associated with your reflux disease. But in our country, still I would say that squamous cell carcinoma is still more common, although adenocarcinoma has been picking up. So in other Western world, lower third esophagus carcinoma is the most common, but if you see in India, the middle third, that is will be the most common, and squamous cell carcinoma variety still remains a common one. But the incidence of squamous cell is decreasing and adenocarcinoma is increasing, and maybe in future adenocarcinoma will take over squamous cell carcinoma in our scenario as well. So squamous cell carcinoma still is the most common, more common in males, and it occurs in upper and mid thoracic esophagus, and it is associated with smoking. Adenocarcinoma is in lower third. So how to go about investigating a patient who presents with dysphagia? So first thing is you have to first differentiate between benign and malignant causes. If somebody has progressive dysphagia of short duration, then you, and in a individual who is more than say 50 years, 40-50 years of age, then you will think more common in terms of malignant disorders. So if your suspicion is of malignancy, then the first investigation is upper GI endoscopy. If your clinical impression is a benign disease, then you may go with barium swallow first also, but upper GI endoscopy in any case has to be done, but you can do barium swallow before that. And if you on upper GI endoscopy you find a lesion, you do a biopsy that will give you the diagnosis. Once you have done a biopsy and it shows a malignant tumor, then you have to do further staging. Further staging is usually done by a computed tomography scan, which will give you details about the local disease as well as the local lymph nodal involvement, as well as some idea about metastasis. And PET scan is usually done for distant metastasis. So once you have diagnosed malignancy, the treatment depends on the stage of the disease and general condition of the patient. Curative options are surgery. Obviously, if you remove the tumor completely, the complete removal of the tumor is the only curative option. And in squamous cell carcinoma, chemoradiotherapy may also be curative in some patients, but although there are no head-to-head comparisons, and whatever studies are there, the survival is comparable between these two. But if some patient, if any patient is fit for surgery, then obviously that is the preferred option. If surgery is not an option, then you can also try definitive chemoradiotherapy as a curative option in these patients. If suppose patient doesn't have a curable disease, either there are metastasis or it is locally invading the important structures, like because esophagus lies in close proximity of great vessels like aorta, it is near the atrium, heart, and near the airway like trachea and main bronchi. So if those are involved, then the disease becomes locally unresectable. When we call esophageal cancer to be locally unresectable when there is involvement of structures which cannot be removed. So if vertebra is involved, you cannot remove a vertebra. If aorta is involved, if a heart chamber is involved, if airways are involved, these tumors won't be locally resectable. So they are called unresectable. On the other hand, if there is involvement of only pleura, pericardium, any structure which can be removed, azygous vein, so these all structures can be removed, so the disease will still be resectable. And suppose if the disease is unresectable or there are distant metastases, then obviously there is no point in removing the disease, local disease. Then palliative options will be there, like you can put in a endoscopically you can put in a stent to relieve dysphagia, because that is the most worrisome symptom in these patients, and people want palliation of that. And then you can give radiation therapy or laser therapy. All these will be used for palliation of dysphagia. Benign tumors of esophagus and cysts, they are very rare as compared to malignancy, but out of these, leiomyomas are the most common. So they will be around 60% of the benign lesions of esophagus. So leiomyomas, they develop in the muscular wall of the esophagus. So generally they won't cause dysphagia because they generally push the esophagus to a side rather than compromising the lumen. They have to be very big in size to cause dysphagia. And they can be diagnosed seen on endoscopy as smooth bulge of the mucosa, and then they can be further diagnosed on radiology like a CT scan, which will show fat containing the smooth lesion in the walls of the esophagus. They can be either excised or enucleated if they cause symptoms. Fibrovascular polyps, again these are benign lesions. They form by they arise from mucosa, and they are they grow in size, but they are benign, and they may be removed either endoscopically or if they are very large size, they can be surgically resected. Corrosive ingestion can be accidental, suicidal, or homicidal. Acid ingestion causes coagulative necrosis and it forms an scar over the mucosa, and that prevents further injury, while alkali ingestion leads to liquefactive necrosis. So it eats away all the tissues and there is deeper injury. So alkali ingestion causes worse injury and more risk of perforation as compared to acid ingestion. And obviously the severity will depend upon what type of substance, whether a dilute or a concentrated acid or alkali amount of the intake and duration of contact. All these will determine the severity of the symptoms. So sign will be immediately there will be edema, and the most important thing which can kill in this patient is development of respiratory distress. So they can have laryngeal spasm which may lead to airway occlusion and the hypoxia. So these patients may require emergency tracheostomy during the acute stage. And dysphagia usually will develop when the stricture is developing. They'll have odynophagia first, and then over the time when the injury is healing by fibrosis, then they will develop strictures and then develop dysphagia. Endoscopy can be done, but it is generally endoscopy can be done in the initial 48 hours, but you have to stop at just when you see the injury. You don't want to injure it further because your scope can cause perforation. So the moment you see esophageal injury, you stop at that point and you do not go further. So your endoscopic examination stops at that point. There is no need to do full endoscopy in this patient because of the risk of perforation. Once the stricture has developed, then you can do a barium swallow to characterize the stricture. And you can also see the direct do a direct hypopharyngoscopy. Your ENT colleague can do that to look at the upper aerodigestive tract to see whether there is associated injury to the vocal cords, epiglottis. All these areas can be seen. In the acute phase, obviously you want to secure the airway and breathing and circulation first, and after that in the chronic phase, once the acute phase is passed, you can, if there are strictures, then you can do endoscopic dilatation, or sometimes you can do stenting of the esophagus, and sometimes then if they are not responding to that, then the surgical options will be there. Typical motility disorder is achalasia, where there is failure of relaxation of lower esophageal sphincter. So the swallowing mechanism is hampered as there is lack of peristalsis, and when the food bolus reaches at lower esophageal sphincter, it doesn't